There are several states in the US that if I diagnose someone as autistic, I am required by law to report them to the state government. They have these autism registries that if you're autistic and if you're diagnosed, you have to be reported to the state health department. And there's no consent there. You just have to be.
Traditional therapy models often position clinicians as the experts. But what happens when this dynamic overlooks the lived experiences of neurodivergent clients? How can mental health professionals create a more equitable, affirming, therapeutic environment? Dr. Amy Marschall shares insights from her work as a clinician and author of Neurodiversity-Affirming Therapy, What Every Mental Health Provider Needs to Know, on bridging the gap between traditional mental health care and neurodiversity-affirming therapy. That's straight ahead on episode 251. I'm Emily Kircher-Morris, and this is the Neurodiversity Podcast.
What is neurodiversity? You see the world differently.
Autism spectrum.
Gifted.
Complexities that are inherently inside.
ADHD.
Dysgraphia.
Tourette's.
All brains are different.
You are exactly what this world needs.
This is the
Neurodiversity
Podcast.
We're nearing the end of 2024, which brings to a close the 6th year that we've been creating this podcast. When we released our first episode in 2018, we were hopeful that we'd be able to grow, and it's amazing how many people's lives we've touched. Thank you for being a part of this growing community and the work we're doing to create a neurodiversity-affirming world. Looking forward to 2025, we've got big things on the horizon. The publication of my new book, Neurodiversity-Affirming Schools, Transforming Practices So All Students Feel Accepted and Supported, with my co-author, Amanda Morin, is coming up in January. Also, we're continuing to grow our educator and therapist hub communities and expand our library of continuing education courses in the Neurodiversity University. Since we're accredited CE providers through the National Board of Certified Counseling, we're excited to do the important work that is the topic of this episode, training clinicians to support neurodivergent clients. If you're curious about any of the courses we have available, head on over to neurodiversity.university and check them out. Okay, Dr. Amy Marschall is with me next.
Previously on the Neurodiversity Podcast.
Change is a brave act. People become remarkably comfortable in their level of discomfort if they just sit in it long enough. I think there's definitely a coping aspect to that comes into play, and we have to say, okay, if we're helping someone cope with something in the process of change or in the process of just experiencing their world, that has value.
Yeah.
And I think more often than not, rather than solving your problem, is learning how to be aware and learning how to be able to tolerate frustration as part of the human experience. And I think that's something that we actually do very little of culturally these days, less so than maybe was present when I was a kid, for sure.
That's episode 154. Find it wherever you get your podcasts.
Dr. Amy Marschall is with me today. Amy is a clinical psychologist focused on trauma-informed and neurodiversity-affirming care. She is the author of A Clinician's Guide to Supporting Autistic Clients and the forthcoming Neurodiversity-Affirming Therapy, What Every Mental Health Provider Needs to Know. Amy, thank you so much for being here.
Thank you. Thank you for having me.
So, mental health clinicians are often some of the first people our clients interact with about being neurodivergent, whether that is through the process of assessment or they're seeking out support for a recent identification. But there is a lot of work that those of us in the field need to do to really shift into a neurodiversity affirming framework that can truly support our clients. Can you talk a little about the change from more traditional therapy models to that neurodiversity affirming approach?
So traditionally, and as you know, you're in the field as well, traditional therapy, mental health treatment approaches really emphasize that expert versus client approach, that I'm credentialed, so I know these things. You're not, so you don't. So you need to listen to me and do what I say. And if you don't do what I say, it's because you're not working hard enough, or you're not compliant, or you're resistant, which, of course, first of all, that there's the false dichotomy of provider and client. A lot of us who are providers are also neurodivergent ourselves, and then also completely overlooks the importance of that lived experience in determining what even is helpful for supporting someone's mental health. The historical approach, particularly with neurodivergence, has been the overarching goal is, how do we make you stop being neurodivergent? How do we make you, it's a meaningless term, but how do we make you act normal? How do we make you stop inconveniencing the people around you, instead of how can we support you? What are your goals and values? And understanding that internal experience of living as a neurodivergent person in a world that's not designed for your brain. So there's been a lot more vocalization from neurodivergent communities of, you need to listen to us. The Autistic Self-Advocacy Network motto, tagline, whatever the correct term is, of nothing about us without us, that, why would you do this work without centering the people that you're supposedly here to help, basically.
Yeah, it's been kind of this transition from behavioral supports and approaches, basically, that really are about shifting the way you're thinking, the way you're reacting, all of these different things. Not that that's not maybe still part of what we're doing, I think, as clinicians.
Yeah, and I mean, developing skills to cope with distress is an important piece of it, because no matter what changes we make on a systems level, like, there's going to be stressors in the world. There's going to be things that are upsetting for you. Like, we can't guarantee we're not going for no negative emotions ever. It's just, we're shifting from, you need to become neurotypical like us because we're better than you because we're neurotypical, to, hey, this neurodiversity is not a bad thing. Like, humans are all different from each other, and that includes, we all have different brains.
We talk a lot about that power imbalance. You kind of alluded to that in the therapeutic relationship and counseling and training programs. We talk about this mostly from an angle, I think, of making sure that clinicians engage in ethical behavior. But there's this other piece of how power dynamics really impact therapy when that one person is viewed as the expert, which sometimes I think leads to that clinician discounting that person's lived experience. So talk a little bit about why it's so important that clinicians really reevaluate their role as the expert.
You don't know. You might be an expert on the DSM. You might be an expert on a specific treatment, and that's wonderful. And I'm not, that's not discounted at all, but you literally can't be the expert on another person's brain more so than they are, because they're the one living in there. They're the one existing. Even clients that I see who share my diagnoses, even my same combination of diagnoses, I don't have their experience inside their brain, just like they don't have the experience inside my own brain. So it's important to remember, I'm not saying clinicians don't have expertise. We absolutely do. It's just that that's not the end all. And that collaborative approach makes us more effective to the individual sitting in front of us, because no matter how much I learn about autism and ADHD, each individual is a whole new, like, every new client that I evaluate is someone I have never evaluated before. I don't know them. They're new. So that collaborative approach, and it's important to stay humble, because no matter how much you know about a topic, you're never going to know everything about the topic. That's just not possible.
The neurodiversity movement really talks so much about depathologization of all of these different traits. And there's also this recognition and discussion about self-diagnosis. But I know for me as a clinician, it's kind of an interesting place to straddle all of that and try to reconcile it. What are your thoughts about that as a clinician?
So just yesterday, in one of the in a Facebook group that I'm in for a particular neurodivergent community, I won't, it's a private group. I won't ruin anybody's privacy, but this individual is living in a country that has the public system that you go through to get your diagnosis. And they were informed that they were going to have to wait more than 10 years for their appointment. So first of all, if I'm going to say, you shouldn't self-diagnose, then I need what is that individual supposed to do for the next decade while they wait for their appointment if we're not allowed to self-identify? Second of all, I know how much an assessment costs. I had 2 of them done. I conduct them, and my rates are below average, but it is still expensive. And a lot of that is because as much as I like to help people, I also am passionate about living inside and eating food every single day. So there's that, I like to say I didn't invent capitalism. I just live here. I try to be as affordable as possible. Not to sound braggy, but I was running the numbers, and I have done pro bono work this year, for the equivalent of about $60,000 US of me giving away clinical services and not being paid for them. So, but the point, circling back on that, it's expensive. Not everybody can afford to get assessed. Not every evaluator is good at their job. I had to get reassessed because my first assessment really left me feeling like you really overlooked some things. It was a very invalidating experience. Some things that they said really didn't match my experience at all. So officially, the first time I was assessed for autism, I was told you're not autistic because autistic people don't work full time and autistic people don't get married. And I'm like, well, you knew that I had a job and a husband when I requested this appointment. So why did you charge me $1,000? You could have just told me that on the phone when I called. If you can get an appointment, if you can afford an appointment, and then if that evaluator has the competence to understand the different ways that neurodivergence can manifest and has worked through those biases, which is, by the way, another reason why we want to stay humble no matter how much expertise we have, because people who had gone through some very extensive training told me you made too much eye contact during this evaluation to be autistic. And we know how masking works, and we know that difficulty with eye contact is something that a lot of autistic people experience, but not every single one. Those barriers, if you can get through all those barriers to get officially diagnosed, self-diagnosis has to be something that we accept on some level just by nature of so few people have the ability to be diagnosed, to get that in their medical record. And then, whole other tangent here, you get it in your medical record, there are risks associated with that. I have a friend who's in the middle of a custody battle that their ex is saying, they're autistic, I'm not, therefore I'm a more qualified parent. And the judge said, you're right. And cut off this person's access to their children purely because their medical record says that they're autistic. There are several states in the US that if I diagnose someone as autistic, I am required by law to report them to the state government. They have these autism registries that if you're autistic and if you're diagnosed, you have to be reported to the state health department. And there's no consent there. You just have to be. So for example, I'm licensed in North Dakota. I don't do autism evaluations in North Dakota because they have this registry. And I've spoken to residents of North Dakota who have said, I feel like I really identify with these traits. I've got the whole history here, but I don't want to be on a government list. So I'm not going to get tested. And you know what? That's fair. There were cases in the US and the UK in 2020 of autistic people who were hospitalized for COVID, finding out that their physicians had put a do not resuscitate in their medical record without their consent. And that wasn't exclusive to autism. That was many different disabled communities found that they were being given DNRs without their consent. It, thank God, got overturned, but Missouri briefly tried to pass a law saying that if you're autistic, you can't have gender affirming care because how could an autistic person possibly know their actual gender? So, I've talked to people in Missouri who are like, I don't want that in my medical record. I'm trans and I want the option to go on hormones, and the government is threatening to take that away. So if you're going to say you're not really neurodivergent if you self-diagnose, then you've got to make it possible to get diagnosed and safe to have that in your medical record.
Well, and I live in Missouri. I had clients who were impacted directly by that law. I like that perspective with the self-diagnosis. So if we know that we need to really recognize those experiences of neurodivergent people through that therapeutic process, what is it that needs to be done to bridge that gap between what clinicians are trained to do and what their clients share with them? And additionally, I guess on the flip side of that, how might neurodivergent people, what do they need to do to make sure that their experiences are heard and understood by that therapist?
The hard part from the neurodivergent client's perspective is that they can do everything right. And if the provider is non-affirming, it's unfortunately not necessarily within their control. But you have the right, if you have a poor experience, you have the right to say, I'm not coming back to this individual, to this provider. Of course, therapy deserts. I mean, I live in South Dakota. I know therapy deserts exist, unfortunately. So sometimes it's, I see this person or I see nobody. Telehealth has helped with that. So if you're comfortable with telehealth, you can often get more options for providers, which I love. By the way, we're coming up on the end of the year, and it was guaranteed access through the end of 2024, and the government has not extended that. They need to. Please call your representatives. But you do have the right, if you're having that kind of experience, to say this is not appropriate for me. I'm not going to continue being seen by this individual. And then again, it does again become a bit of a dance and being careful. And for example, with the ADHD community, you say the wrong thing to a provider who has certain biases, and they put in your medical record that you're drug seeking, and then you never get medical care again. I don't mean to sound terrifying, but it's very much on us, the clinicians, to fix the system, because our clients are really at our mercy.
So what are some of the things that clinicians need to do in order to shift that for themselves?
It's a lot of unlearning. Unfortunately, we talk about reducing stigma. We talk about being educated in these things, but a lot of the stigma, the call is coming from inside the house. It's the training programs, it's the providers, it's the folks who have this idea. Again, the false dichotomy. You're either a client or a provider. You can't be both. There was, I think he was a medical doctor doing anti-stigma work, and made a post, I think it was on Twitter, of him taking either an ADHD medication or an antidepressant, talking about it, saying it's okay to ask for help. It's okay to struggle with your mental health. And people called his licensing board. Strangers called his licensing board and said, you need to take away this person's license to practice medicine because he takes medication for mental health. And, it's this idea that you can't be competent if you need support for these things, which really feeds that expert, client versus provider mentality. Because if you assume I can't be a competent psychologist if I'm neurodivergent, the implication there is that a neurotypical person is superior to a neurodivergent person, because only a neurotypical could help someone with their mental health, which is not true. And again, I'm not, even if I were neurotypical, I'm not better than my clients just because I had privileges that allowed me to get through a graduate program. So we need to humble ourselves, and we need to educate ourselves, and we need to listen to the people that we claim we're here to help. How much of your practice is guided by voices from the community that is your niche? And that should be a high number. Otherwise, what are you even doing?
Right. So many neurodivergent people just really haven't had positive experiences in the past with therapy, because their neurodivergent traits were pathologized or because the treatment modalities were actively harmful. So kind of looking at this both from the perspective of the clinician and the client, how can people heal from that previous therapeutic harm?
And it is absolutely a form of trauma, which makes it harder to get. It's kind of that cycle that the thing that's supposed to help me through a trauma is the thing that caused some of the trauma. And so I think having these resources, like, for example, there are some directories for providers who specifically commit to being neurodiversity affirming, who, like, you can't be listed unless you document that you have taken steps to take this approach. And, it's certainly not being perfect. We're all, no matter how much education you have, we're all going to make mistakes, but it's that willingness to listen and that seeing that as a lifelong learning process. But people deserve the knowledge of, here are the risks that come from a provider who sees themselves as an expert who's smarter and better than you. And here are resources to find a provider who very deliberately does not take that approach.
Yeah, that healing process too is just such a long and involved experience if you have had those negative experiences. I mean, I know for me, now granted, I didn't have any therapeutic pieces, but just growing up, I think many adults can realize this, but growing up and being neurodivergent and not being supported, like even in the school setting, was really harmful. And there's a lot of unlearning that goes along with that.
When we talk about adverse childhood experiences, I think being neurodivergent should give you a +1 to your ACEs score, because that is a chronic stressor. And regardless, like, I thought I was neurotypical till I was in my 30s, which looking back is hilarious. But the stress of growing up neurodivergent and not knowing it, and then even when you do know it, the harmful approaches that a lot of these kids are subject to, like, I'm very careful. Like, it's not a contest, and I'm very careful to not say that one is better or worse than the other. There are people who I get identified as adults who are like, oh my God, why? I wish I had known this when I was a kid. I spent my entire academic career thinking that I was lazy or like just not good enough, and, all these negative self-talk. And then you get people who were identified as kids who were like, yeah, I was put through this therapy to force me to sit still. And, essentially I knew I was neurodivergent. So I had a team of therapists telling me that I was fundamentally flawed and bad and wrong and needed to change who I was. So, I'm not comparing the two at all, but certainly I think being neurodivergent is in itself a stressor when you're existing in a world that is not designed for your brain.
Yeah. I want to touch briefly, you mentioned this a little bit, but about the difficulty that people have finding qualified clinicians to work with them. First of all, it's just hard to find therapists who understand neurodivergence in general, but even more so for people who live in rural areas. So you said you live in South Dakota, so I'm sure you're highly aware of the people in your state who don't have access to care. So is telehealth the best option, or are there other considerations?
So it depends. There is a lot of research that shows that in general, telehealth is comparable to in-person care as far as the quality and, like, the treatment outcomes, whatever we decide that means, but that you can get the same quality of service via telehealth as you can for in-person. A small percent of people just really don't take to telehealth. And a small percent of people just really don't take to in-person and do better with telehealth. So in general, it's indisputable at this point. The research shows that telehealth is an option. And there is research even on the assessment side. Again, as long as the provider is trained, because telehealth is different than in-person and it is its own unique skill set. But as long as the provider has the appropriate training, they can do diagnostic assessments and therapy via video with the same level of quality as in person. So telehealth really opens up those options. And I mean, I'm not saying that it needs to fully replace in person, because again, there are people who really prefer it. There are situations where telehealth isn't appropriate. Like, for example, if a client is in a situation where there is domestic violence in the home and they can't guarantee that their space during their sessions is actually private, then it's a safety issue. And then there are some circumstances so there aren't, according to the APA, there are no diagnoses that automatically say you should not receive telehealth. But for example, some people who experience certain delusions can struggle with telehealth. If, like, for example, if the delusion is I'm getting secret messages from my electronics, it can be harder to engage with a therapist via your electronics where someone is actually sending you a message. So, it's not that it's not like this solves everything, but it really does open it up. Like, I'm in South Dakota. I'm also licensed in Montana. South Dakota recently joined PsyPact, which is an interstate compact that allows psychologists to practice across state lines. So when a South Dakota client reaches out to me, if I'm not able to help them, I can recommend any PsyPact psychologist who would be able to potentially see them if they're available. They're allowed to practice across state lines. Montana has not joined PsyPact. So when someone from Montana says, I can't find anyone in the state, I have to find someone who's actually licensed there to be able to help them. And that's that becomes very difficult in states, prior to July of 2024, South Dakota was not PsyPact. And Montana is still not PsyPact. So when you're like, I have to find someone who's licensed here, it gets very difficult to do that.
Yeah. And it's confusing for clients. I know at our office, we have people who contact us all the time, not recognizing what all of those laws are. And it's tricky. And it's about where the client is, not necessarily where the clinician is.
It's the client's location at the time of service. And then depending on your licensure. So like with PsyPact, I credentialed with PsyPact like the second they would let me. I can only practice PsyPact while I am physically in South Dakota. So if I go to Minnesota to visit my family, I wouldn't be able to do anything PsyPact related, even if I have an office and compliant HIPAA, confidentiality, everything is kept. As soon as I leave South Dakota, my PsyPact, I can't do that until I get back to South Dakota, which is strange because I asked them the reason for that rule. And they said that it's because if a PsyPact provider receives a complaint, the licensing board of their home state has to cover it. So the state of South Dakota needs to be able to reach me if there's a complaint. But the state of South Dakota doesn't care where I am at the time that I practice with my South Dakota clients, because my licensure agreement just says if the South Dakota board reaches out to me and is like, you've had a complaint, I have to comply with them. And if they say you have to come to South Dakota to address this, I have agreed to comply with that and to travel. So
many things to consider, but it is getting better.
Yeah. The reciprocities have been fantastic, and I hope that they continue. I know a big concern around it is if you're not licensed where your client is, can you ensure that they get appropriate support if they experience a crisis, which is that is a valid concern. People do sometimes need crisis support, and it is our responsibility to make sure that we know what resources are available for that. But I can, name a state and I can tell you the local crisis resources within 30 seconds just by Googling them.
Yeah.
Also, regardless of their location, my consent paperwork simply has every single client indicate an emergency contact who is physically local to them.
Yeah.
A lot of it comes down to concerns that were very valid at one time, but the technology has evolved to address those concerns, and the law needs to catch up to our abilities now.
So whether someone is a neurodivergent person or a clinician or a parent or an educator, I'm curious if you just have some ideas about broadening the practice of being neurodiversity affirming beyond the therapy room and into just daily life. Like, what are some of the things that we can all do on a day-to-day basis that use those neurodiversity affirming principles in our regular interactions?
Well, and it has to be. If you only do it in your office, then you're not actually committed to it. I mean, this has been a whole hot topic lately of like, can you be affirming to your clients if outside of the office you're voting for politicians who are actively trying to hurt them? Like it's not just, if you just do it in your office, then you're not really doing it and you're not really addressing the biases, because maybe I'm being naive, but I think that in a lot of cases, and if not in most cases, where a provider does harm, in that moment, the provider thinks they're behaving ethically and thinking that they're helping their client. There are a lot of providers who conduct so-called therapy that have been proven by the research to do more harm than good. And if you ask them, why do you do something that harms your clients? They would say, I don't harm my clients.
Yeah.
So if it's not, if it's just in the office, then it's not really there. But there's the educational commitment, of course. There's the listening to the people. Again, if you're not elevating, if you're not centering people who live with what you're there to help with, if you're not listening to that community, how can you really help them based on their own values? And no community is going to have 100% agreement on anything. So that's why you still individualize to each particular client. But for example, if I want continuing education in how to support clients living with certain mood disorders, I'm going to seek out education from someone who lives with the diagnosis that I'm trying to learn about, so that they can speak to, what it's like to have that experience from their lived experience. I feel like I'm saying the word experience a lot, but to have that commitment. It's also a big part of being visible to the people that you're there to serve. I know that, there's a whole lot about I don't like the term marketing, because it feels weird. Like I'm marketing, I'm not here to advertise myself or whatever, but actually the editor of my book that's coming out next year, the Neurodiversity-Affirming Therapy, reframed it for me, and I ended up using this terminology in my book. But it's not marketing, it's visibility. Because how can you help people if they don't know that you exist? So how do you make yourself visible? And how do you very clearly indicate, these are my commitments? One thing that we're seeing with the neurodiversity affirming movement is that a lot of people have turned it kind of into a buzzword. And it's become, oh, I'll get more referrals if I say that I am neurodiversity affirming and if I slap a rainbow infinity sign on my website, with no idea what that means and no actual education. They've just figured out this symbol makes people call me. So being very vocal about things helps clients to determine who's safe to go to. Practicing in South Dakota, one of the reasons why I have an active professional social media experience is because a lot of clients, for example, in the LGBTQ community, might be concerned seeking out a provider in South Dakota. Are you going to be affirming, or are you secretly a conversion therapist? Because that's still legal here for some reason. And they can Google me and they can see, here is what I have said about my practice. Specifically, I didn't just throw a flag on my website. When South Dakota was banning certain gender affirming cares, there's photos of me at the protest saying, don't pass this law. So it's, you kind of, when someone's identity is political, therapy is political, and our clients deserve to know, is this a safe, they shouldn't have to schedule and pay for a first appointment with me to find out if I'm going to say, well, have you ever tried not being trans?
Agreed. So, Amy, this has been such an insightful conversation, but it brings me to our last question. If you were talking to a neurodivergent person who's trying to find that just right clinician to support them, but they're uncertain or wary, what would you say to them? What is it that you would want them to hear?
That's completely valid that you're uncertain. I'm sure that there are reasons why you're not sure about either seeing someone or knowing who to look for. I really like the ndtherapists.com. It's a directory that everyone listed in it has identifies publicly as neurodivergent. Now, I don't think that it should be compulsory to disclose that you're neurodivergent as even if you are a professional. Obviously, I posted my diagnosis on my website. Obviously, I share mine publicly, but also, acknowledging that I am in a place of privilege to be able to safely do that. When I first got my diagnoses, I was working for an organization and I did not share publicly that I was autistic until I became self-employed because I did not feel safe with my boss having that information about me. So not all neurodivergent therapists are going to be in a place to be like, yes, I am neurodivergent. They could have very valid safety concerns around sharing that information. But so ND therapist is all providers who are in a place to disclose I am neurodivergent. There's also the neurodivergent practitioners directory, and that one you don't have to be neurodivergent. But both of these directories have a commitment that you sign and you agree to in order to be listed. So clients can look at that commitment and see everybody who's listed in this directory has publicly stated, I support this approach to care. I have taken these specific steps to not inadvertently harm my clients, to recognize that importance of lived experience. So finding people who are very vocally and specifically committing to that, getting recommendations from your fellow community members can be huge in determining. And it's not a guarantee, fit is so important. And a lot of that comes down to just personality kind of stuff. And that's okay. And also it's a great starting point for at least someone else knows that this person is taking steps to not actively be harmful to my community.
Dr. Amy Marschall, author of Neurodiversity-Affirming Therapy, What Every Mental Health Provider Needs to Know. Thank you so much for talking to me.
Thank you.
If you or someone you love is neurodivergent, it can be hard to find professionals who understand that unique brain wiring, but it isn't impossible. Amy mentioned that there are a couple of sites that offer listings of clinicians who are either neurodivergent or specialize in supporting neurodivergent clients. But the biggest factor about finding a clinician who is a good fit is finding one who listens to you and tries to help you find solutions that work for you and your family without changing who you are. I'm Emily Kircher-Morris. I'll see you next time on the Neurodiversity Podcast.
Thanks again to Amy Marschall. We have links in the show notes for more information. Also, if you're still devoid of ideas for a gift for someone you know who listens to this podcast, maybe something from our merchandise store would hit the spot. I'll put a link to it in the show notes as well. Our music is by the artists of Epidemic Sound. Find us on social media via links in the show notes and on our website, neurodiversitypodcast.com. We'd like to welcome our newest staff member this week, Corey Orrick. She's our new office manager and social media guru. Welcome, Corey. We're glad you're here. Our host is Emily Kircher-Morris. I'm the executive producer, Dave Morris. For all of us, thank you for listening, and we'll see you next time. This is a service of the Neurodiversity Alliance.